Okay, welcome everyone. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I would also like to pay my respects to all elders past and present. So welcome all of you to this session, this satellite entitled Designing Products That Meet Community Aspirations, Understanding and Use Preferences for Emerging HIV Biomedical Prevention Technologies across East Africa and India. My name is Jean-Daniel Lelièvre. I'm professor of immunology in the University of Paris-Est Créteil in France, and I'm currently the senior manager of the HIV vaccine enterprise at the International AIDS Society. I would like to introduce my co-chair, which is here for this meeting today, Ethel Makila, Director of Communication, Advocacy and Policy at IAVI Kenya. I would like also to welcome all the participants, both here in person, but also virtual, as well as our speakers and panelists who will be introduced to you shortly. This will be a 90-minute session initiated by 4 presentations, followed by a panel discussion. The session is organized by us, the Global HIV Vaccine Enterprise at the International AIDS Society, in collaboration with IAVI. So the session will provide insights on the acceptability of virus prevention products among specific vulnerable populations across East Africa and India, and will also deliberate on technology advances and health system delivery lessons in the post-COVID era. Obviously, it's important when you want to buy and to define prevention technology to follow the scientific rationale to develop them. But it's also important to follow the aspiration of the community. For instance, I came here in Brisbane using a plane because it's mandatory to use a plane to come from France. But if I want to go from one place to another in France, I have several options. I can use, obviously, a plane, but also a train, a car, or even a bicycle. So everything you want to buy something and to buy the newer prevention tools, obviously you have to take in account the fact that you have a scientific rationale to buy it. You have also economic impacts, but you have to take into account the needs and the specific aspiration of the target populations. So the discussion will help guide product developers in defining the unique value proposition for upcoming prevention intervention, account for specific importance to critical product attributes, and identify effective communication channels and delivery strategies. It will also help funders to direct investment to areas where they are needed. Most importantly, the session will emphasize the need to have community voices and user choices at the heart of product development. So we encourage our audience in person and online to send your question to our presenter at any time using the QR code that will appear on the screen through the session. In-person participants are also welcome to come up to the microphone and to ask their question directly. Question will be addressed during the panel discussion at the end of the session. We kindly ask all the speakers to deliver their presentation within the allocated time, because time is everything, and to allow time for the panel discussion. And then now I will hand over to Ethel to introduce the first speaker.
Thank you very much, Jean-Daniel. Today we have a very outstanding panel of speakers from East Africa and India. And it is my utmost pleasure to invite Yvonne Mashira. She'll be the first presenter. Yvonne is the Director of Social and Behavioral Research at IAVI, and she's based in Kenya. Yvonne, welcome to the podium, and she'll be giving a presentation on injectable and implantable long-acting PrEP, facilitators and barriers to uptake and adherence among adolescent girls and young women and female sex workers in Kenya and Uganda. Yvonne.
Good morning, everyone. It's a pleasure to be here. So I'll be referencing a study called Uptake, which is a study that's been running since the end of 2020 in Kenya and Uganda. I'd like to start by acknowledging all our funders who make IAVI's work possible. And here to introduce the consortium that makes up the Uptake study. So this is a study that's led by the IAVI team and with our partners Busara. We also have the East Africa Health Research Commission, CAVI in Kenya, we have the MRC in Uganda, as well as London School of Hygiene and Tropical Medicine. And this project or study is kindly funded by EDCTP. So just a little background around the Uptake study. So this study was designed about 4 years ago. And the process around its design began, informed by aspects related to oral PrEP uptake and adherence. And even though oral PrEP, as we know, is actually efficacious in preventing HIV, there were quite a number of challenges around users actually sticking to the regimen intended. So generally, oral PrEP uptake has been suboptimal. And we were also thinking around aspects related to BNABs, which are under development, and thinking, okay, we are having challenges around ARV products such as oral PrEP. What would happen if a long-acting product such as BNABs were to be introduced, or even a HIV vaccine? So given that CABLA was at the time, in the pipeline around, being studied as a potential product that could actually prevent HIV in the long term, or rather for a longer time than oral PrEP, our thinking was around what do users think about a product such as that? So we had a lot of studies that were telling us around oral PrEP barriers and facilitators for use and adherence, but we really had very limited studies or information that could actually tell us around long-acting products. So Uptake was designed as a 4-staged study, and what I'm going to be referencing is the first stage of the study, which was really keen on looking at the kind of factors, whether it's interpersonal or social, that motivate end users to either decide to use the products or not, and also to actually adhere to the products or not. And this is a study taking place in Kampala as well as in Nairobi. So this next slide is an illustration of the design of the study. So because we really appreciated the fact that end user preferences are a complex topic, and it would be very difficult to actually get a comprehensive picture, just from a cross-sectional perspective. So we designed it in 4 stages. So the first stage, which was the formative stage that was concluded in 2021, was really to form the foundation of us understanding what are the factors that influence people's motivation to use products that are, preventing pregnancy, contraceptives, as well as preventing HIV, and kind of trying to understand how those preferences would actually inform behavioral experiments that our colleague Francis will be talking about. And so we also understood that even when we actually design behavioral experiments and apply these to the end users, that it would be it would also not give us a full picture. So it would tell us, okay, this is how we quantify the preferences, or these are the utility values around the preferences. This is how the decision making is actually working out, or these are the parameters that inform use of products. So we knew it would also be important to actually have a cohort study and monitor the participants for a period of time to be able to see the real life decision making and use of this product. So what you'll hear from us today is mainly around the first stage, the formative stage, as well as the behavioral experiments that were carried out. Now, I'd just like to add that the formative study targeted adolescent girls and young women aged 15 to 24 in both countries, as well as female sex workers aged 15 to 45. So in the thinking of our conceptual framework, we did look at quite a number of models around acceptability of HIV prevention products as well as other products. And we were trying to conceptualize it in the sense of, what are all the factors we can try and capture in our questioning. So we were asking questions around product characteristics. We were also asking questions around motivation to use this product, as well as barriers around using this product. And because we do understand the strength of social influence in using and adhering to these products, we were also asking around societal influences, as well as perceptions around this product. And we did go ahead to speak to policymakers as well as healthcare workers to get the feasibility perspective, but this presentation really is focusing on what the end users came up with. So we talked to 30 adolescent girls and young women and 31 female sex workers. And for both populations, we divided them into 3 groups. Those who had been on family planning products and had discontinued, those who at the time of the study being undertaken were still using this product, and those who had never used this product. And we actually carried out interviews with them over a period of 8 months. And since these were qualitative interviews, they were audio recorded, and we used in vivo for thematic analysis. A little bit about our participants. So the adolescents we spoke to in Nairobi, as well as Kampala, the mean age was about 21. Sex workers in Nairobi were a mean age of about 27 and 29 for Kampala. We were also querying education level because we do understand this kind of social demographics do influence decision making as well as knowledge of this product. And as you can see on this chart, for Nairobi, for the adolescents, for most of our participants, they had been to high school with a minority only up to primary school, and some having no education. For the sex workers, most had only been to secondary school, some only up to primary level. And we kind of had a similar split with the AGYW in Kampala, as well as for the sex worker category. We also did ask the participants about their relationship status or their partnerships. So for the adolescents in Nairobi, you can see here most were in casual or unsteady relationships. And then we had about 6 being in long-term or steady relationships. In Kampala, which it was interesting for the adolescents, most were actually in long-term or steady relationships. Then when it comes to the sex workers, in both countries, most were in casual or unsteady relationships, given with the nature of their jobs. We also did ask about whether they had children or had experienced a pregnancy. And for the adolescents, it was a 50-50 split in terms of those who had and those who didn't have children. And for the sex workers, we did have most of them actually having children. So this was important for us because it also informed their use of contraceptives as well as HIV prevention products, which we were querying. So I'll now just quickly go into the findings, which I'll talk about in terms of 2 categories. So on the one hand, I'll give perspectives around what were the preferred product characteristics, as well as features, as well as what are the kind of factors that actually influence these preferences at various levels. So on the first point around preferred product characteristics, it was very clear for, in terms of multipurpose prevention technologies, participants preferred those that were long-acting. The preference was a year plus, and the preference was also more around injectables and implants. So even in terms of the participants who are using family planning products, these were the preferred products. Participants also expressed a preference to actually have dual protection for HIV and pregnancy. We did also ask them about where they would like these products delivered, with most preferring that they're offered in health facilities. One of the aspects we were querying about was whether home visits were something that they would like, but perspectives came up around discreetness, around the delivery of the product, so they preferred to actually do it themselves. We also asked around how these products are administered, and many preferred a healthcare worker to actually administer. Most preferred an injection on the arm. A few others mentioned either on their thigh or buttock. And something that came up with a lot of participants was around the packaging. So with oral PrEP, the packaging is not discreet, and participants really talked about this being an aspect that they would like. And in terms of what would inform their adherence and retention support or follow-up, they did talk about the need for prompts, say by SMS or via social media, as well as an option to have an online delivery system only if the packaging was actually discreet. So in terms of the factors influencing what made them like some products and not like some products. At the individual level was frequency of administration. So with oral PrEP, for instance, as a daily pill, that was not preferred. They also wanted products that do not have as many side effects. Mode of administration was also something like that came up. So for instance, when queried about the dapivirine ring, participants were feeling that, vaginally inserted products were not preferred. From an interpersonal perspective, peer influence did really come up, as well as whether the person was currently in a steady relationship or not, so that influenced what product they used. They also did talk about the fact that if a healthcare provider recommended a product, they would most likely, go for it. From a community or social perspective, stigma was a huge factor. There were perspectives around FP and HIV prevention product use that, alluded to aspects related to their sexuality, and especially also for the younger adolescents. There were also misconceptions around these products, and especially family planning products, for instance, that they would result in infertility later on. At a structural level, aspects related to the healthcare system, accessibility of services came up, affordability also came up, as well as the quality of care. So overall, as I summarize and conclude, adolescents generally had more limited knowledge around both FP and HIV prevention products compared to sex workers. Education level played a big part around this knowledge aspect. Sex workers generally had a higher risk perception, especially around HIV, due to the nature of their work. Sex workers also did talk about the fact that they don't disclose their product use to their clients when it comes to family planning or oral PrEP. And they also talked about aspects related to support from family members or at a social level. So the social factors that were really coming up were around stigma and discrimination, which is one of the subjects we'll discuss as a panel. Social norms around what products to use or not use, what are your peers using or not using, what do people think when you use certain products. Aspects around GBV also came up, especially with the sex workers who indicated that as they interact with clients, they have experienced violence that results in non-HIV prevention product use. And I think I've already talked about the myths and misconceptions, so I won't talk too much about that. And from a structural level, it's really important for us to actually acknowledge the fact that access to comprehensive SRH services does play a big role. But as does criminalization, and this played a big role, especially for sex workers and the kind of stigma they face, as it's actually illegal to practice sex work in both Kenya and Uganda. So in summary, there is a high level of awareness of products, but more among sex workers than adolescents. There was generally low levels of knowledge around PrEP and PEP, as well as future long-acting HIV prevention products. Discreteness, long duration of protection, less side effects, easy accessibility were aspects that were preferred around accessing these products. And if preferably, they could prevent both HIV and pregnancy. And from the government perspective, it was very clear that there are aspects related to the moral or the value-based system of a country that actually determine the structural factors that make products available and being offered to end users. So this was actually an important aspect that needs to be considered as well. Great. I'd like to acknowledge the uptake study team. It's a huge team, as you can see here, from various partners. And I'd also like to really acknowledge the 81 research participants who made this study possible. Thank you all for listening.
Thank you very much, Yvonne. Very insightful presentation. Next, I'd like to invite Dr. Venkatasan Chakrapani, and he's a chairperson for the Center of Sexuality and Health Research and Policy, which is also referred to as C#. So, Dr. Venkatasan.
Good morning, everyone. Thank you for the introduction. I'll be presenting findings from a study that focused on choices or preferences regarding PrEP, rectal microbicides, and HIV vaccines among men who have sex with men in India. This is a team effort. As you can see, there are several co-authors. So India has a concentrated HIV epidemic, concentrated among key populations like men who have sex with men, transgender women. The Indian government has an ambitious goal of bringing down the new infections by 80% by 2024. But as you can see, so far, the reduction in new HIV infections has been only 37%. So there is still a long way to go. At the same time, if you look at the consistent condom use among MSM, it is very low, actually, suboptimal, 50 to 55%. So obviously, we require additional new HIV prevention tools to help in reducing these new HIV infections, especially among key populations. But there are several tools which are available, as you know, we have PrEP, we have rectal microbicides and HIV vaccines, which are in the pipeline. So as these new HIV prevention tools are available, it is also important for us to understand the end user preferences and perspective for success of introduction of and also uptake of these new HIV prevention tools. So we conducted this study to assess the willingness to use 3 biomedical HIV prevention tools, oral PrEP, rectal microbicides, and HIV vaccine. And also we wanted to assess the choices or preferences for product characteristics. So we conducted a cross-sectional survey among men who have sex with men in 2 cities, Mumbai and Chennai in India. So we did what is called as a discrete choice experiment, which I will elaborate. So this was conducted in 2017. At that time, oral PrEP was not approved by the regulatory authorities in India. Subsequently, it was approved in 2018. And we recruited men who have sex with men from cruising sites and drop-in centers with the help of 2 community-based organizations in Mumbai and Chennai. And we used what is called chain referral sampling, similar to the respondent-driven sampling. And the study received ethics approval. So the main outcome measure was looking at the acceptability of these 3 HIV prevention tools. So this is the single question which assesses the acceptability or the willingness to use. But ultimately, we converted into yes or no, like a binary outcome, like whether they are willing to use or not use. We used the very likely. If they have said very likely, then we meant that to be accepting that particular product to use in the future. So discrete choice experiment is traditionally used in marketing research, but it is increasingly being used in HIV prevention related research as well to understand end user preferences. So using this methodology, we can able to find out the evaluation of the entire product by the participant, and to select the attributes and levels, like the characteristics of the products, like we used literature review, we conducted a formative qualitative research, and also we piloted DCE among 16 MSM. So ultimately, we came out this list of attributes and levels. We identified 5 attributes to be of potential importance in uptake of these products: efficacy, dosing, cost, side effects, and venue. So efficacy, we kept in 2 levels for across the products, 50% and 99%. And dosing were different for different products, as you can see. And cost, we had a lower cost and upper cost. And side effects for all the products, it is either none or minor. And venue for oral PrEP and HIV vaccine, we kept that as private hospital and government hospital. For rectal microbicides, we kept that as pharmacy and community-based organizations. So we conducted this DCE using SmartPad, and this was administered with pictorial cards on the tablet screen, which I'm going to show. And among the 600 MSM, we divided them into 3 groups so that 200 MSM answered the questions related to each product. So this is a DCE session in progress. So this is an example of a scenario, a set of choices. Here I'm showing the oral PrEP. So you can see basically there are 5 profiles of oral PrEP, and the participants, we asked them to choose among the 5 which is the best and the worst. So that becomes say first rank or second rank, something like that. And then in the remaining 3, then again they have to say which is the best and which is the worst. So for example, here the participant has selected the first one as worst and the 4th one as the best. So we used the standardized methods for analyzing the data from DCE. We used what is called RPL models. So basically it is similar to the logistic regression. So coming to findings, so broadly the socio-demographic characteristics of the MSM are primarily they are from lower socioeconomic status and lower educational status as well. So across the 3 groups, we could not find any differences in socio-demographic characteristics. So coming to the main outcome of acceptability, so if we take the options of both likely or very likely, then nearly 90 to 93% they told that they are willing to take this product. But when we take only very likely to take product, which we actually used for this analysis, you can see it is anywhere between 46% to 50%. So this diagram summarizes the main results of the DCE. So basically we wanted to know what are the attributes that significantly predicted acceptability, and also the relative ranking of the attributes in terms of the strength in predicting acceptability. So this relative ranking is based on the magnitude of the odds ratio, which is a measure of association between the attribute and acceptability. For all products, efficacy was the strongest and significant predictor of acceptability. Here you can see the diagram for the efficacy. For all the products, the product profiles with 99% efficacy had higher odds of acceptability. Coming to the relative ranking of other attributes in predicting acceptability, there were slight differences in relation to the type of product. For oral PrEP, the relative ranking order was, as you can see, dosing came 2nd, side effects 3rd, cost 4th, and venue 5th. Among these, the levels which significantly predicted the acceptability were for dosing 4 times per week, for cost, lower cost, for the venue, government hospital, and for the side effects, obviously, like no side effects. Similarly, for the rectal microbicides, the relative ranking order was side effects came second, dosing came third, venue came fourth, and cost came fifth. And among these, the levels of these attributes which significantly predicted acceptability were product profiles with no side effects, no applicature, choice of venue delivery being community-based organization, and also the lower caste. In relation to the HIV vaccines, the relative ranking of other attributes, of course, the first rank is the efficacy, the second one is the side effects, third dosing, fourth cost, fifth venue. However, here the venue was not actually a significant predictor of the acceptability. As you can see, the confidence interval crossed the odds ratio of 1. Among these, the significant levels which predicted acceptability are no side effects, 1 dose per year for the dosing, and for cost, it is obviously lower cost. So we also did subgroup analysis. I'm only presenting the findings from the subgroup analysis in relation to engagement in sex work, yes or no. So in relation to oral PrEP, both those who engaged in sex work and who did not engage in sex work, they preferred higher efficacy. And among those who engaged in sex work, they had a stronger preference for higher efficacy when compared to those who did not engage in sex work. For those who did not engage in sex work, they had a stronger preference for government hospitals. Coming to the rectal microbicides, those who engaged in sex work, they had a stronger preference for higher efficacy. Those who did not engage in sex work, they had a stronger preference for applicature, and also the preferred venue of delivery was community-based organizations. In relation to HIV vaccine, there was no significant difference in the strength of preference between those who engaged in sex work and those who did not engage in sex work. So coming to the summary, so this study identified both key attributes and levels that influence the stated choices or preferences for the 3 products. So this new knowledge can help in refining the candidate products, the new upcoming products for HIV vaccines and the rectal microbicides. And as you can see, like there was considerable diversity in relation to the degree of preference of attributes across the subgroup which I presented, like engagement in sex work or not. So some of the potential action points which we can consider include like development of targeted education programs for using the products, and also about the relatively low side effects of oral PrEP, which is widely available. Identification of delivery venues that are acceptable. Also, the findings highlighted the need to tailor educational interventions for diverse subgroups in terms of whether they engage in sex work, whether they have lower socioeconomic status, like that. So with that, I think I will stop the presentation. Thank you very much. Yeah.
Thank you, Dr. Venkatesan. Yes, and that was the presentation on PrEP, rectal microbicides and HIV vaccines, preferences and willingness to use among men who have sex with men in India. So our next presentation is a tag team between Joyita Mukherjee and Saif Ulhad. Both of them are from Ayavi, India, where Joyita is the senior manager for research and development, and Saif is the director for access, policy, and behavioral research. And the presentation is titled Broadly Neutralizing Antibodies, Acceptability Among End Users, and Key Health Systems and Programmatic Perspectives from Health Service Providers and policymakers for potential introduction as prevention products in India. So I'm going to welcome you. I think we will start with Joita. Welcome.
Thank you so much, and a very good morning to everybody present here, and also good morning, good evening, and good afternoon to all those of you who are joining us virtually. Today we're going to present from a study which was done in India on HIV broadly neutralizing antibodies, their acceptability and feasibility among at-risk populations in India. We will be presenting this on behalf of the study partners, the Hamsafar Trust, C-Sharp, YRG Care, and Final Mile. We acknowledge all our donors, especially USAID, who funded this study. We will begin with an introduction where we focus on the current HIV prevention toolbox. As we know, there has been a lot of development which has happened over the last few years on the prevention toolkit, and like we see, there is a very diverse toolkit which is available, with some of them which are currently available, some which have just recently been approved, and some which are in the development pipeline in trials. These include the products which we are going to speak about today, the broadly neutralizing antibodies. BNAbs are a non-antiretroviral based prevention option, and they add to the diversity of the toolbox. There are two ways in which we can look at the BNAbs. They can be either introduced for passive immunization, where they are directly administered and they are able to neutralize the HIV, or we can also use the vaccine approach where we have immunogens which are administered and they elicit broadly neutralizing antibodies within the body. So that gives us potential applications of BNAbs where we can focus on using BNAbs as prevention tools, also treatment or cure. We'll be focusing on BNAbs as prevention tools. We have over 200 BNAbs which have been discovered. Some of them are in clinical trials, including few by IAVI. When we have such a diverse toolkit, the question is, why do we need so much of choice, and do we need more products? For this, I would like us all to focus on the aspects of where end users are at the center of the product use. And when we look at that, we have diverse populations who have diverse needs. Each one of them is at a different stage in their life journeys. There are social contexts which are evolving and they are not constant at every stage. And we also have changing priorities for the end users. All of this taken together gives rise to varying preferences, and which is why we have distinct choices which end users can make at any point of time. So we should be allowing end users to weigh the advantages and disadvantages of different products and make the choice based on what is best suited for them at a particular time. And that is a reason why we should have distinct value propositions defined for the products, keeping in mind the diverse needs of the end users. So with that in mind, we did this study to understand the factors which drive the choices that end users make. What are the factors which they consider when they are either choosing one product over the other? Is it just one aspect which is stable, or is it certain things which are dynamic and keep changing with time? A bit of focus on the research design and the methods. We had two objectives. The first one was on understanding the product preferences and behavioral factors which influence their uptake and adoption. We had a multi-step process here where we had traditional qualitative research. We started with an open-ended exploration of product attributes where end users were asked to mention which are the most preferred attributes and what would they want to see in those attributes as various levels. Once we heard them, we moved to the second stage where we had an exercise where they were presented with product bundles. And this is where we try to understand their trade-offs, the reasons behind why they were making a certain choice. So this aspect focused more on the why of their choices. That is what we call the bundled choices exercise. We moved to the next stage where we used a simulated behavioral experiment. And we try to understand the preference construction pathway. How is it that an end user moves through the journey of making a choice? That is where we used scenario-based experiments. They were presented with various scenarios, and the fact was that they didn't have to answer it as a one-to-one interview. It was more like answering it for others where the aspect of using the rational thinking was brought into picture, and we were able to focus more on mental models, heuristics, and biases which come in when people make choices. And lastly, we ended with, are there certain aspects of preference reversal which is possible, and how do end users move through that path? The second objective in the study was focusing on understanding key health system and programmatic perspectives, and how certain things should be in place if we have to consider the introduction of BNABs as prevention products in India. And we conducted key informant interviews with health service providers and policymakers across different parts of the country. So the study was conducted in 3 regions: Delhi in the northern part, Mumbai in the western part, and Chennai in the southern part. The maximum diversity sampling was followed. We do want to focus a bit on the various profiles which were presented to the end users in the choice experiment. The first one was modeled after oral prep. So these were hypothetical profiles which were created. The driver behind creating these profiles was to create a conundrum to the end user, so that they have to really put on their thinking hats and see what they would like to choose. And then we wanted to capture what was the most important driver and how were they making the choices. So profile 1 was a pill which had to be taken once every day, self-administered, with side effects like nausea and headache. Profile B was modeled after long-acting PrEP. The study was conducted 2 years back. So the profile that we had for this was pill plus injection, so laden oral pill for 5 weeks, and then followed by injection, which was 1 per 2 months. This would be administered by a healthcare worker, and the short-term injection side pain as a side effect. Profile C was modeled after the broadly neutralizing antibody injection, which had to be given like 2 injections every 3 months, administered by a healthcare worker, and short-term injection side pain. And lastly was the profile D, which was a multipurpose prevention technology modeled after the MPT, which was an implant administered annually, administered by a healthcare worker, and short-term incision side pain. We'll come to the study findings. They are in 2 parts: the acceptability findings and the feasibility findings. The conceptual framework for acceptability was used as the basis for the study, and the findings are also structured as per this framework. This was adapted from the theoretical framework of acceptability by Seacon et al. And the conceptual model by Mensch. They have been divided into 3 parts: the product factors, the intrinsic factors, and the extrinsic factors. When we come to the open-ended exploration for the study, there were certain findings which were under the product factors. For the efficacy, what we found is end users preferred a minimum efficacy of 50%, but what they preferred was 70 to 90% as the efficacy. For formulation, we had mixed responses for oral versus injectable. People said they preferred oral for some populations, and some populations preferred injectables. Subcutaneous and intramuscular were definitely preferred over intravenous injections. For the frequency and the number of injections, once in 3 to 6 months. The reason provided for this was it matched with their HIV testing schedule, and 1 injection per visit, though some of them did mention that they were okay to have 2 injections per visit if it was absolutely essential to have the desired efficacy. The preferred site of administration, we had again mixed responses. Some preferred arm because of the familiarity and the minimum intrusion of privacy. Others preferred buttocks because of better pain tolerance. Place of delivery, ART centers were strictly avoided because of the association of stigma, and mostly community-based centers were preferred. For self versus assisted administration, self-administration was not preferred because people felt that they would need certain level of knowledge to have the injections, and also they were afraid of the side effects, or if they had a wrong usage, the impact that it would have. They rather preferred taking it from trained professionals. The intrinsic factors which drove their decision-making, they had certain perceived benefits which they had in mind. For example, higher efficacy of injectables. People associated injectables with higher efficacy. They felt that it would provide them efficient protection against unsafe or forced sex. And also, they associated greater autonomy due to reduced dependence on male clients for condom use. The perceived burden, what did bother them was the side effects, and they were okay to accept minimal or minor side effects, but they were They were concerned about the major side effects like impact on fertility, caregiving, or any kind of impact on any major organs. Emotional, they did say that the breach of privacy was something which they were concerned about. High out-of-pocket expenses, they did want to have it at a subsidized cost, or rather free of cost if possible, and anything which was above $20 was considered to be unaffordable. And use of broadly neutralizing antibody was associated with weaning condom use because it would lead to a reduction in condom use if they were taking any other prevention product. Coming to the extrinsic factors, interpersonal influences, concerns about disclosing the product usage, their family, peers, partners, did play on their mind because it came with the perception of either being HIV positive, or they said that it would perhaps be assumed that they are involved in wrong behavior or promiscuous behavior. And also the social influences like societal stigma and discrimination was a concern for some of the populations. Coming to the preferences for the product bundles, like we said, we had 4 different profiles which were presented to the end users, and we did have a lot of preferences which came in for profile A and profile C. What you see on the screen are the reasons which people gave behind why they would choose or not choose a particular profile. We also wanted to highlight how people were making these choices. And through the analysis of the data in the study, we do think that these are certain end-user goals which people were associating with when they were highlighting the reasons for their choices. So if you look at profile A, the fact that it was a daily pill, they felt that it was too much of an effort to remember to take it daily. We also see that the fact that it was resembling ART regime made end users feel that there was a lot of stigma which was associated with it, and long-term usage was associated with side effects. However, they did see that this was something which helps them maximize their control because they can take it when they want, where they want. It would also mean minimal pain or discomfort, and it means minimal disruption to their life in terms of any invasiveness. For profile B, they felt that it was a complex regime because it had pills plus injections. Also, the profile highlighted that it was a buttock administration, so that would increase their uneasiness and it would have an intrusion in their privacy. And the fact that it was both a pill and injection would mean that it is twice the burden and twice the effort. For profile C, the major reason that was highlighted was that the fact if it was non-ARV based, it would have less side effects and less stigma would be associated with it. They were comfortable with the frequency and the site of injection, the arm was also comfortable, which is why they associated it with effort reduction, stigma avoidance, and privacy maximization. For profile D, though it was an attractive choice, where there was annual administration, so they felt that there would be better adherence, but what didn't work in favor of this product was the scarring, which would have an impact on their beauty or aesthetic look, and it was also going to be associated with breach of privacy. And of course, it was considered to be more invasive, more costly, and which would cause more pain. But they did align with the goals of effort reduction and minimal disruption to life. Because profile A and profile C were the profiles which had kind of a lot of factors which was working in favor of them, but also a lot of factors which did not work in favor of them, there were certain mental models and heuristics and biases which we are going to consider here, which is on intrinsic pleasantness, efficacy, access, privacy for pills and injectables. I'll not go into the details of this, but we will come to the preference construction pathway where people have feelings and emotions which they consider. How does the product make them feel? How do they feel about the product? And there are certain greens which worked in favor of the product and certain reds which don't work in favor of the products. We also have rational considerations, and there is a constant push and pull between things which work in favor and things which don't work in favor, and the ones which are highlighted in bold are the ones which drive their decision making. At this point, I'll hand over to my colleague, Saiful Adib, to take us through the preference reversal pathways. Thank you.
Thank you so much, Joyita. So as we saw from her presentation, that human choice is incredibly complex. nuanced, and consequently not very stable and open to change. And so for product developers, it's extremely important to not just understand choices for products and drivers of that choice at a particular moment in time, but actually across life journeys, and take into account and understand some of the drivers that lead to changes in these choices. The ways that we used to study them was through the simulated and gamified behavioral experiment that Joyita alluded to previously. And the methodology really hinges on not just asking questions and seeking oral responses for hypothetical situations, but simulating real life environments and choices so that these tensions and push and pull factors between feelings and emotions, conscious and non-conscious drivers of choice, as well as some of the pros and cons of each product can be felt in real life scenarios. Based on that, we were able to identify both bidirectional change mechanisms that could potentially impact preferences and choices of end users. So one leading from the pathway from rejection to conditional willingness or acceptance to use the product. So for the broadly neutralizing antibodies, the causes of rejection of this product among those users that identified that was unfamiliarity or mistrust or lack of confidence in a new category or class of product, the fear of needles and uneasiness with excessive exposure, and the burden of memory in terms of remembering it at a 3-month time or to 6-month time frame. In terms of the drivers for reconsideration, that that if there were social proof and contextualization of info provided on the safety of the product, they would be motivated to change their choice or reconsider. And also, if there were a reduction in the frequency of administration, that would lead to a recalibration and conditions that could assist the reversal of this preference, where they would likely see the product as a less risky option that many people are using, that's also associated with lesser stigma, and they have an enhanced coping ability with the various burdens associated with product use, leading eventually to willingness. Similarly, from willingness, the pathway to potential, unwillingness or discontinuation of use. There, the factors of acceptance, the strongest ones were, non-antiretroviral based product that was less associated with stigma and a high estimation of their self-efficacy and coping ability in terms of using the product. What would result in perhaps a reconsideration of this would be the recognizing the immediacy of the burden of product use versus the distal rewards of protection. And in terms of reluctance, that would be the wavering motivation in the face of considering the burden of memory, the burden of travel and accessing the product by standing in long lines that is typically associated with injectable use in the Indian context that could potentially lead to unwillingness. And moving on to quickly this second objective of the study, where we used a framework to understand the feasibility from the perspective of policymakers. This had contextual alignment in terms of the contextual need within the Indian context, integration with the existing programs and program capabilities, building on new workforce proficiencies and capabilities to deliver this product, as well as supply chain and logistical management related perspectives. Some of the key learnings that we had was that not just for the end users and healthcare providers, but also for policymakers, antibodies were a new class of product. And consequently, educating on antibodies and monoclonals as a class of product was necessary. And this is where cross-disease based existing monoclonals, particularly in the COVID use scenario, and most importantly in rabies, which in the Indian context, there is an existing immunoglobulin that is available at significantly lower cost through public health systems and being successfully delivered by public health professionals at the PHCs in the states of Gujarat and Kerala. So these were important lessons that should be derived to enable a positive attitude towards the introduction of monoclonals among the Indian policy landscape. In terms of human resource requirements, that intramuscular delivery would enable minimal amount of training required, since even at the lowest levels of the health system, this is routinely done. And trusted CBO networks need to be leveraged to the maximum in order to facilitate trust within the product itself, and also safeguard privacy from the end user's perspective. In terms of policy and budgetary considerations, there was a need to generate in-country evidence on the health economic impact that this product would have, and also, retain the existing cost of $1.20 per vial that is available for the rabies immunoglobulin. So lastly, in terms of recommendations for product developers based on the information that this study generates, the first is that, there are diverse needs and choice drivers among all of these different populations that we studied, and consequently, the unique and distinctive value proposition of the product needs to be spelled out for each of these categories separately. For female sex workers, focusing on the autonomy of use and the privacy of use and delivering through community networks was extremely important. For adolescent girls and younger women living in a high-risk environment, discrete use and the non-ARV aspect that leads to a lesser association with stigma was extremely important. For pregnant women, as for pregnant and breastfeeding people and caregivers of infants, minimal implications on pregnancy and maternal health was something that was extremely important alongside efficacy. For transgender women, a sense of security, and particularly for communities most at risk of sexual violence, was something that was important, and perceived minimal interactions with gender affirmation therapy. And for adolescents and younger MSM, the reduced frequency would leading to better adherence as well as lesser stigma, and focused messaging with respect to risk compensation were important factors to be considered. In terms of the key distinctive value of this product, usability and convenience was at the very top, alongside a perception about minimal side effects. Privacy maximization was also very important, and the non-ARV factor was also consistently observed. In terms of delivery factors, fewer pricks were highly preferred, and delivery through trained professionals was the choice, not self-delivery. And addressing drug-drug interactions, particularly for gender affirmation therapy as well as opioid substitution therapy, was extremely important. And in terms of policy considerations, the need for country-specific data and evidence to be generated on the effectiveness and cost-effectiveness of the product was extremely important, and trusted CBO networks were to be leveraged in order to ensure that there was high uptake for this. That's in a nutshell, and once again, we thank our donors. Thank you so much for your patient listening.
Wow. Thanks so much, Saif and Joyita. And we're coming to our final presentation before we go into the panel discussions. And I'd like to invite Francis Mayo. He's the Vice President for Busara Center for Behavioral Economics in Kenya. And he's going to be making a presentation on the multi-purpose technologies, market segmentation studies among adolescent girls and young women and female sex workers in Kenya and Uganda. So Francis, welcome to the podium.
Thank you, Ethel, and thank you everyone for being here. My study borrows heavily from Yvonne's. It's the same study. I'll be presenting part 2 of that. Similar to Yvonne, I would like to thank our donors for this project and thank our research partners as well. I'd like to begin my presentation by positioning the work and the reason we're all here as well. There's been a lot of social behavior change communication strategies around HIV and AIDS in the past. And in the recent past, there's been a lot of advancement around biomedical products and technologies being introduced. And I'd like to position that in a way that behavioral insights are still required with these new biomedical products that are being introduced in the market. The uptake study sought to understand barriers and levers of usage of contraceptives and HIV prevention products among female sex workers and adolescent girls and young women in both Kenya and Uganda. We did this through a quantitative study and a DCE, so we'll be borrowing a lot from what has already been covered as well. And we are leveraging behavioral science to not only identify preferences of long-acting HIV prevention products, but also suggest testable behavioral interventions that are likely to enhance uptake of these products among target end users, but also ensure adherence of the product use as well. So We recruited 322 HOAWs and 330 female sex workers. The sample was balanced roughly across both HOAWs and FSWs in both Kenya and Uganda. There's a lot of there was a good age distribution across HOAWs and a balance across FSWs, as these graphs show. I'd like to highlight some of our findings in terms of contraceptive awareness and use. If you look at my third column, you'll see relatively high levels of awareness across HOAWs and FSWs for the various contraceptives. Not surprising, one of the highest ones is male condoms, right? Both at over 90%. When you go to the last column and you look at the use of all these both long-acting and short-acting contraceptives, the usage does fall quite dramatically, right? So even with male condom use, it's about 48% for both HOAWs and FSWs. Injections are slightly below that, 35% and 43%, and the others are really quite dismal. So even with the introduction of all these new products, even though awareness may be slightly high, product use remains quite low. And we see a similar trend with various HIV prevention methods as well. Male condoms, again, at 98%, usage 92, 86, but most of the other products around here, awareness is low and usage is even worse off. Now, we did this behavioral segmentation exercise, and it was to determine the types of HOAWs and FSW segments that exist in relation to their potential use of future long-acting HIV prevention and multiple-purpose technology products. This would enable us to understand their current behaviors around sexual activity, contraceptive use, HIV prevention methods, and other behavioral factors that were key in distinguishing the two segments. Now, in addition to the demographic profiles that we are constantly looking at, we'd like to look at what are the behavioral profiles of both the HOAW segments and FSW segments. There's quite a lot of numbers there, but one that I'd like you to focus on is on the objective risk for both for the two segments that I present here, and the subjective risk for the two segments that I present here. So for segment one, who's most likely to use HIV prevention methods, the objective risk is at about 35%. So that is how did we judge them to be at risk of contracting HIV, and would they then use the products to prevent that that exists out there? While the subjective risk is what do they think of themselves, what's their risk profile as well. So our cautious girl in segment one is most likely to use it. Our adventurous girl in segment two is least likely to use these HIV prevention products. This was the HOAW segment in Kenya, beg your pardon. Moving to the HOAW segment in Uganda, we found three segments that exist: the trusting girl, the believing partner, and the doubting partner. And again, if you look at the objective risk at 31%, and the subjective risk at 15%, slightly different with the subjective risk at 67%, and the objective risk at 31% for the believing partner, who's in the middle between most and least likely to use it. And then the doubting girl, objective risk at 41%, and a subjective risk at 81% as well. Moving to the FSW segments, which was interesting, at least for me, to see that the objective risk was similar to the HOAW segment in Kenya that we found at 38%, and a subjective risk at 34%, which was a little bit similar for the carefree woman. And then second segment, the conservative woman, an objective risk of 72% and a subjective risk of 36% as well. And FSW segments in Uganda, we found that they had an objective risk of 58% for the cautious woman, a subjective risk of 31%, and for the trusting woman, an objective risk of 39% and a subjective risk of 39% as well. what we found from this was some of the behavioral factors that would influence the uptake and adherence as well of HIV prevention products include the risk preference, the stigma, intimate partner violence, the locus of control, peer influence, subjective risk, and age. We'll be looking at behavioral messaging interventions on drivers of uptake of PrEP, and we'll be testing this in the next phase of our work. Some of the interventions that we are curious to explore would be peer influence, testing if high-status peers have an influence on health choices, testing the risk preference, if associating health choices with personal risk preference affects product choices for both uptake and adherence, and the locus of control, testing whether priming people on their self-efficacy to take charge of their health outcomes affects their health choices. And the implications for this is perceived side effects is a significant barrier to the uptake of HIV prevention products. To increase acceptance and utilizations, we should focus on addressing concerns related to side effects. The effectiveness and easy accessibility are among the most valued product features as well. Therefore, we should make these as salient as possible. And targeted outreach interventions, such as targeted education campaigns, peer support networks for both HGYWs and FSWs should be adopted to circumvent unique barriers that these key populations may face. Thank you.
So thank you, Francis. So I would like to thank first all the speakers for their very comprehensive presentation. They allow us to have a very large and complete overview of the preference of the different prevention tools among different populations in two important parts of the world, India and then Africa. Your presentation were very complete, but I'm sure that we will have a lot of questions from the audience on your presentation. So now I hand over to Ethel for the panelist discussion.
Thank you very much, Jean-Daniel. Very insightful presentations, very diverse, and yet somehow there were some similarities, some similar threads running through all the, the different analysis and the findings that you had. And I'll pose my first question to you, Dr. Venkatesan. And this is just because in your organization, the word research and policy, that's part of the title of your organization. So I'll pose it first to you. And then I'm also going to let other panelists respond to this. And we're looking at the path of research to policy and practice. Yeah? And what are the lessons that we learn when we look at the differences between the data from the surveys and from the discrete choices?
Thank you. Yeah, I think so. Of course, there have been some surveys conducted even in India, looking at the willingness to use, especially PrEP. I have conducted those studies as well. So the main difference between the findings from those kind of surveys and DCE, of course, DCE itself, we have to do it in a survey form. So DCE is a kind of like, say, similar to a randomized control trial. So in the other surveys, the routine surveys which ask about willingness to use, we usually ask about like questions I showed you, like about their willingness to use or acceptability. But usually the product level characteristics or level will not be the focus. Primarily the what are the significant predictors in relation to socio-demographics. So those kind of analysis will be done in the routine surveys. But in DC, the very specific focus is on identifying what are the significant characteristics, attributes of the products. In addition to that, we also looked at the preferred venue of delivery. So those are like some differences which can actually inform the product developers and also the policymakers. For example, if a particular choice of venue is coming up, like whether it is community-based organizations or government hospitals or private hospitals. So accordingly, the program, the managers or the policymakers, they can then say like, okay, we need to deliver these products through these menus. So that is the idea, like for established products like say oral prep. For the new upcoming products in developmental pipeline, the preferences will also then give some ideas about what changes they can make in the attributes of the products, like rectal microbicide. For example, if we take the rectal microbicides, we asked about whether it is whether they prefer with applicator or without applicator. Without applicator in the sense whether the rectal microbicides can be used like a lubricant along with the condom, so there is no need for the say applicator. So one thing which we found, I'm taking this as an example, one thing which we found was like the sex workers, they did not prefer the applicator, because if they are standing in the hot spots and then they are engaging in sex work, for example, every 1 hour or 2 hours, they are going to meet with a sexual partner. So they will not be then say applying that every time. Like they don't want that kind of applicator. So that actually, like this kind of analysis and also the subgroup analysis to check how the preferences differ also gives an idea about the context, which are the real things which are happening in the settings. And accordingly, we can design the programs which are like specific for particular subgroup. So these are some examples of implications for the policymakers and also for the product developers.
Thank you so much. That was very comprehensive. Does anyone else in the panel have anything to add to that? Francis.
Sure, thank you, Yville. I think what I may add is for surveys and DCEs, we've used them as well, and we found them to be very useful. On the survey thing, as regards to measurements, we found that perhaps self versus peer attribution, particularly for HOAWs who may be more sensitive, may result in truer measures as well. So when you're trying to get to subjective risk of what are people's actual sexual behavior, the number of partners, the use of all these products, at times peer attribution gives you a better measure than the self-attribution part of it. Thank you.
No question from the room, so I will move to the second one. So some of you have already raised the place of the neutralizing antibody on the prevention tools. And we know that monoclonal antibodies are right now quite important tools for prevention against infectious disease such as RSV or recently, obviously, COVID-19. So I'm wondering where could BNABs complement the current prevention landscape, and what gap in the HIV prevention tools do monoclonal antibody fields? So maybe a question for Saif or Joyeta.
Thank you. Thank you so much for that question. And as you very rightly said, that there is currently a lot of hope, aspiration, and excitement with respect to monoclonal antibodies. Of course, in HIV, they're far back in comparison to the other examples of RSV and COVID-19 in terms of where they are currently placed in the developmental pipeline. But as our study showcased, that from both policy, program, and healthcare service delivery side, there is a lot of hope and excitement, and also from the end user. And one particular driver of that choice that we were able to identify through the study was that antiretrovirals, people are really looking to go beyond them. So they're absolutely essential, and they're playing a very prominent role. But at the same time, there is an emerging group or class of target populations and end users that are demanding for products that go beyond existing antiretrovirals. And that space currently is not occupied with too many prevention tools. And that provides us this really opportunity to make sure that we invest in, we make sure that, that these newer prevention technologies are people-centered, so that we have rapid adaptation and uptake from this population that's actually demanding for this particular type or class of products. Perhaps Joyita can talk a bit more in terms of their applicability for pregnant populations and infant groups and so on.
Right. Yeah, I think when we did this study, we also focused on a little bit of sample size, which included pregnant women and caregivers of infants. And when we asked them about whether they would be willing to accept broadly neutralizing antibody as prevention products, they were willing to accept it, while they did acknowledge the fact that PMTCT was doing quite well. But then there were certain gaps which were highlighted in terms of how that wasn't going till the 100% mark. So in order to sort of meet those gaps, the complementarity of another option was something which they were willing to accept. Also, what they did mention is they would be willing to give it to the infants, like if there were infants born to HIV positive mothers, that was something which they were absolutely willing to provide, and also the pregnant women themselves, unless they saw a very huge risk to their health from this product. That was the only thing they were concerned about, but otherwise there was acceptability from this population as well. So that's something that we wanted to highlight.
But one thing that is not always clear for me is I understand the difference between oral PrEP and BNABs, but when you compare, for instance, a long-acting antiretroviral and BNABs, what are their feelings, what are the difference they see between the two?
So one factor that we mentioned is that, at the community level, that there is this association that if you're using antiretroviral-based products, then you're indulged in some kind of questionable behavior from prevalent community standards. And the associated stigma is very much prevalent and recognized by members of communities. And consequently, that demand for a non-ARV-based product was one that was quite high, and I talked about that. But over and above that, also, a lot is going to matter in terms of, what kind of frequency and dosing we might be able to achieve through this eventually. And there was definitely an inclination towards using injectable products over oral products, despite this prevalent notion that, oral products don't run out of stock. They're easier to access. Injectables may have stocking-related issues. You might have to wait in longer lines to avail services. But despite that, there was a preference for injectables, and several of the mental models that we identified were in favor of that. And as you rightly said, that that with long-acting injectable antiretroviral solutions available, that's going to add on to a layer of choice that that there is a clear preference for non-ARV-based products. You may end up having a sense of which ones of these which would require lesser dosing and better frequencies of administration, and also which ones would be associated, whether perceived or actual, with lesser side effects in the long run. Because side effects was another key concern that populations that are already familiar with oral PrEP or are increasingly becoming familiar with long-acting injectable PrEP, that was definitely a concern that we had observed.
Right. I just wanted to add that what we also saw from the community perspectives is that how do they construct these choices, or how do they process the decision-making when they are looking at a product, which is where the preference construction journey and the fact that we did simulated behavioral experiments which brought them to a stage where they could respond to some of these choices in a non-intimidating environment helped, because that's what helped us elicit certain things which was going on in their mind but wasn't always brought out in front. And I think that is something which is very important for us to capture, because there are certain nuances which get lost, because at the experiential level, it's at the end of the day injections which end users are going to go for. But when they are choosing for the products, what is it that is considered? Because then at a policy level, we need to be aware of certain steps which are going to have an impact on the final uptake of a product.
Anyone else want to comment on this point? Ashley, I think that there is some question in the audience.
There's a question right at the back.
Sorry, we can't see you. Please.
Thank you so much to the presenters, that was wonderful. One question which I thought, it's a question and a thought to think about. I know you mentioned a little bit about the supply chain, but it was in relationship to one product in terms of how it will be kept in ambient temperature and probably gotten to the people. But I'm looking at these biomedical products as being for a certain population, more at-risk population, which is they do not fall in the mainstream pharma products of most of the countries. And if you look at Africa and India, we share common pathway in terms of our economies and in terms of to supply for basic needs for pharmaceutical products. Have you thought about, in case we promote the use of these products, how will they fit within the mainstream supply chain system to be maintained even after we've promoted usage, but also how the logistics management information system to enable visibility, traceability of these commodities to avoid waste, probably fraud, loss, and expiries. Is that something that has been incorporated into this research? Because in the long term, long run, that also needs to be taken care of, since this will be like special products. Thank you.
Thank you so much for that question, and it's very important and something that we did consider while posing questions to policymakers in the Indian context. And in the Indian scenario, there is incredible diversity in terms of capabilities between the more than 30 Indian states. And what we have something known as the state procurement, logistics, and supply chain related societies for drugs and biopharmaceuticals. And each one of them respond to based on the available capabilities and systems prevalent within that state. So we did pose this question, and the key learning that we had with regards to this was that we have the example of 2 Indian states that are using, human-derived immunoglobulins for rabies prophylaxis and successfully delivering it at the level of primary health care. And so consequently, there are storage mechanisms and systems, there is training mechanisms that already does exist. There are notable differences in the way that you would handle HIV versus rabies, as you very rightly pointed out. But, and that also came up that, those primary facilities need to be linked with the existing National AIDS Control Program, which is largely dependent on using community-based partners for the delivery of services as well as for awareness and testing programs. So consequently, that development and strengthening of that linkage between the two and leveraging on existing capabilities within some states that are successfully delivering it and scaling that to other states were some of the key lessons that were identified through our study. I'm not sure if anyone, Yvonne or someone wish to comment on this from the African context.
Yeah, for the uptake study, we also did speak to policymakers and healthcare providers. And what was coming up more was around issues of product movement or product uptake, over and above the logistics around that SAIF, the logistical issues that SAIF has actually spoken to. So it was around having kind of like dead product because of the issues around access, use, and adherence that we have actually talked about. Thank you.
Is there another question?
Go ahead.
Go ahead.
Thanks so much. I'm Julie with the Military HIV Research Program, and I just wanted to ask a couple of administration questions. One was if either the BNAB or uptake studies looked or tried to tease out intramuscular versus subcutaneous injections, and if you got a sense of preferences or thoughts around those deliveries. And then the second question was just, what do you think is behind the preference for healthcare administered injections instead of self-injections?
Yes, so for the uptake study, we did actually query on intramuscular versus subcutaneous administration of a product. And what was coming up is that for intramuscular, that's kind of difficult to actually do it yourself. So you'd actually need either someone at home to do it for you or a healthcare provider to do it. So in terms of the home option, that was not preferred because, again, that removes the discreteness around the use of the product. So then the second option, or rather the better option indicated, was around actually going to a healthcare provider for that. For subcutaneous injections, so even though that was less technical than the intramuscular bit, there was still the preference that around a healthcare provider actually administering, probably because of little or no experience around administering injections for yourselves. And also, at the beginning, even kind of trying to explain what the difference is between subcutaneous and intramuscular. But injections clearly, even with all these studies, are preferred because it's discreet, and it also offers the option of longer-term protection.
From the Indian perspective, I think we have a bit of similar things which we have heard. With respect to intramuscular and subcutaneous, I think the main association which end users do is with respect to the pain factor. So what is it that's going to give them reduced pain is what the first instance, that's what comes to their mind. And that's how they said that, anything which helps us go for a lesser pain factor is something which we would accept. And also, when we asked them about the mode of administration, it was more like subcutaneous, intramuscular was on one side, intravenous on the other side. So they preferred intramuscular or subcutaneous over intravenous. The nuance difference between the subcutaneous and the intramuscular was something which they played around with, but in relation to the pain factor. Secondly, the mode of the self-administration versus the healthcare provider administration, we found unanimously end users preferring healthcare provider administering it for them, with the exception of people who inject drugs. For them, because they were used to taking it themselves, they were comfortable with taking the injections in a self-administered mode. Also with respect to some of the MSMs who were okay in case they were doing it themselves, but for all of the other populations, it was majorly something where they were going to healthcare workers for. The reason behind that primarily was because they were not, the self-efficacy, they were not sure that they would do it the correct way and how it may go wrong, resulting in something which is not there. So I guess that's what we learned from this study. If Dr. Chakrabani would like to add to it.
Just maybe two quick points in relation to the preference for subcutaneous administration of BNABs. So because I was looking at the data collection from trans people. So those trans women who had diabetes, they had experience in injecting subcutaneous insulin. So they said, like, yes, we can able to do it if it is available, the BNABs are available as subcutaneous. Another is they also talked about informally, like, because for hormone injections, sometimes it is more like a peer-administered hormone injections. So they said, like, maybe this can also be like administered like a peers, like, because we are already familiar with administering, even though it is not recommended, it should be administered by the healthcare providers. But these are the preferences which came from trans women. So just wanted to put that.
That's fascinating. Thanks so much.
I may also have an answer as a medical doctor, because we used to use polyclonal antibodies for people suffering from common immunodeficiency, and most of people prefer to use subcutaneous than intravenous supplementation with immunoglobulins. So we have an online question. So I am curious about what is the cruising site and drop-in center in India? How is the representative of these samples, and what is the scenario of cultural aspect that you can share?
So the question was about the cruisings. Can you say it again?
Yes, what is the cruising sites and drop in the center in India? How is the representative of the samples, and what is the scenario of cultural aspect that you can share?
Oh, okay. So it is about the representativeness of the sample, because I talked about the sample being recruited from the cruising sites and also the drop-in centers. Of course, nowadays it's more and more people, they move into the social media platforms and also the dating apps. Like for example, MSM, for Minverse Excitement, it is like we have apps like Grindr and Blued. So of course, any study, it's very hard for us to have a representative sample of people who are hard to reach or key populations. So I think what we can do is mainly increasing the diversity of the sample in terms of recruiting both offline and online, also from different kind of physical venues. That could be one way by which we can actually increase the representativeness. But because we don't have what they call the universe from which we can choose the sample, it is always difficult to say like we had a representative sample. Yeah. Thank you.
So thank you. Unfortunately, we have to close this session. It was quite an important session. We know that we face a very important field, and that the field will be quite not different in the next months, but in the next years with the new long-acting drug that will be available, new BNAbs that will be available. So it will be quite important to have new meetings like this one in the future. So thanks to all the speakers, to the audience, and to all of you. And have a nice conference today and the following days. Bye.